Okay, good morning, everybody. We are about to start our first lecture in the GIAN Orthopaedic Biomechanics course. And this course is entitled Orthopaedic Biomechanics, Implants and Biomaterials. And myself, Professor Sanjay Gupta from Department of Mechanical Engineering, the principal coordinator of this course. Now, the two lectures that I will give today morning are very basic lectures, which will try to focus on the mechanical aspects of the human body, its structure and function. So we'll look at the human body as a mechanical system. Okay, so there will be some basic physiology, anatomy lectures, but the focus is on structure and function. What is the relation between structure and function of the musculoskeletal system that is at our disposal? So we have a skeletal system, and there are long bones, there are short bones, there are flat bones, there are irregular bones. In total, there are 206 bones in the human skeleton. Now 210, if we count the two sesamoid bones that lie under the head of the first metatarsal in each foot of most people. Okay, so we have long bones like femur, as you can see, and you can see probably here that in the hip joint that this is the upper part of the femur. So I would turn it like that. So this is the upper part of the femur because it forms the hip joint with the pelvic bone. Let us talk about the skeletal organization as a whole. We have axial skeleton, which consists of the skull. You can see here the skull on the top with the red color, red orangish color. Then the thorax and the vertebral column. Okay, and the appendicular skeleton is mostly the limbs that gives us movements. So we have upper limbs, lower limbs, pectoral girdle, and the pelvic girdle, all marked in green in your screen. Okay, green color in the picture. So basically, we can divide the skeletal organization into two types. We have the axial skeleton and the appendicular skeleton. Now, before I move on to the different aspects of the anatomy physiology part, we need to define certain anatomic planes and direction as we do in case of engineering drawing. You remember everybody has done engineering drawing? So you know what is plan, elevation, top view, side view, front view, sectional view. Like similarly, we have certain anatomical planes and directions as well as certain nomenclature for defining certain aspects. So we have the axial plane, as you can see, it cuts through. It is like a plane which is where we can obtain some cross-sectional view. Okay, we have a coronal plane, which is the mid-frontal plane, and we have a sagittal plane, which is a transverse in the transverse direction. So these three planes we will try to use to define different views subsequently in the different lectures. Apart from these three principal planes, we have the directions. So you can see that it is marked anterior is towards front, posterior is towards back, and it is also sometimes called ventral and dorsal respectively. We have superior, superior means top. So by definition of the English language, superior is up and inferior is down. And you can also sometimes say cranial and caudal as the medical, as it appears in the medical terms. So that defines the front, back, top, and bottom. Now we move to more inside the human body, a little bit more inside the human body, and you can see here on the right the anterior view, this picture, concentrate on this picture, and you can see that we have a proximal and distal. Okay, so what we have been looking into this joint, if I look into this joint, oh, it doesn't come here, but maybe we can use the pen. You can see that the top part we will be saying proximal, and the lower part we will say distal, but this is with respect to a particular bone, remember. Okay, so if you consider a sort of femur like that, so this part is basically the proximal part of the femur. The distal part of the femur actually forms the knee joint. You can see this is the knee joint. So this is the distal part of the femur. So this is, everything is with respect to the bone. Of course, you can say with respect to the body, but proximal, distal are the two ends of the body part. Medial, lateral. So we have, when we see an anterior view, anterior posterior view, you can imagine a midline running through the middle of the body. Okay, the axis. Okay, towards the midline is medial, away from the midline is lateral. Okay, everybody could follow? Okay, so if I move my hand more towards my body, I'm trying to move my hand medially. Okay, so towards the middle of the axis. And if I move my hand away from my body, then movement is more lateral. So here also in the lower part we have the proximal and the distal for the lower limb. So anatomical terms we have defined that it is anterior, posterior, which are opposite, superior, inferior, proximal, distal, medial, lateral, ventral, dorsal, and cranial, caudal, all defined in the earlier slide in the figure. Okay. Now let us move inside the human body and just try to give you the basic idea of the femur bone. For example, the femur, incidentally, is the longest and the strongest bone in the human body, and it has different parts. Okay, so we have epiphysis, which is basically the connectors. So femur is connected with other bones in these parts called the epiphysis, here on the proximal side and here on the distal side. Okay, there is the diaphysis or the central shaft of the femur. Okay, this part, and we have the metaphysis, which is basically a part which is in between the epiphysis and the diaphysis, but this is rich with cancellous bone. Now, what is cancellous bone and cortical bone we will discuss later, but this is cancellous bone is porous, spongy bone. Okay, that forms the inner core of the bone structure, and that is basically covered by a hard, dense cortex called the compact of the cortical bone. We will discuss that a little bit later. So this metaphysis is basically regions where there is a lot of muscle attachments. So you can see already here that somewhere in these regions we have a lot of muscle attachments. Oops. Now, as I had indicated in my earlier slide, so this is the proximal part of the femur with the head of the femur, femoral head, which is spherical in nature. There's a neck of the femur, because here the cross section reduces drastically, and there is greater trochanter and lesser trochanter on either side of the femur, and this part where it forms the knee joint is the distal part of the femur. Let us go to the function of bone. So, the bone structure that forms the skeleton actually has certain important functions, which can be summarized as follows. The first most important function is supporting the body weight, okay, providing movement, okay, so that gives you the mobility, and it actually protects vital organs, okay. So you can see that your rib cage is protecting two most vital organs, that is the heart and the lungs, okay. And you have the skull, which is protecting your brain. So all these vital organs are being protected by the bone structure, and supports the body weight, and in conjunction with muscles, ligaments, and tendons, the bones actually enables us to perform different physiological activities. That means, in summary, it provides mobility, okay. It facilitates, very important, it facilitates blood cell formation. So within the cancellous bone, you have this bone marrow. From bone marrow, there is the red marrow, and through a process of facilitation of bone cell formation, this happens within the bone structure, within the cancellous bone structure. And it acts also as a mineral storage, essential minerals of like calcium, phosphate, magnesium, sodium, and potassium. So that provides a summary of the bone functions. The next is the broad classification of the bone structure. Okay, I would, apart from this slide, I would like to show you this sample a little bit later. But you can see we can classically divide bone as compact bone and spongy trabecular or cancellous bone, as I had spelled out to you earlier. So inner core, you can see here a cross section through the femur in the coronal plane. You have spongy bones, trabecular bone, or cancellous bone, and this forms the inner core of the structure, and which is covered by a layer of varying thickness of compact or cortical bone. Okay, this is a cross section through the shoulder. Okay, you see the humerus and the glenoid. So if you look closely here, we have spongy bone, compact bone, and here you can see through the distal, through the shaft of the femur, there is hardly any cancellous bone inside, but a sort of a cavity, medullary cavity, and this is very thick cortical bone on the two sides. So this, if you go down this shaft of the femur, you actually have this type of structure. Now, if I just show you here this probably this one. So you can see, okay. Don't look into other things, just concentrate on the structure. So you can see here how this is forming a network of rods and plates to form the cancellous bone structure, and it is transforming into solid structures towards the compact bone region. But here you can see this is a patient, a sample of a patient with osteoporosis. Okay, it's highly porous cancellous bone and with very low density. And you can see here in the next sample that it can vary from person to person, and with age, actually, the quality of cancellous bone. The more densities, it is better for you. For a healthy patient, the cancellous bone has certain range of densities, but when we actually do DEXA scans for patients suffering from osteoporosis, you'll immediately see that the bone densities in certain critical regions has reduced reduced drastically, and the patient needs treatment. So next, we move to the muscle. So muscles, as you know, are the big brothers of the body, and they provide muscle power. Okay, the muscle power is actually which provides the mobility in conjunction with other parts of the structure, but the muscle actually gives you the dynamicity or the initiation of the movements. So there are about 700 different muscles in the human body, okay, and they can be classified into 3 types. We have the skeletal muscles, we have the cardiac muscles, and we have the smooth or visceral muscles. The skeletal muscles are actually muscles that are attached to bones and moves the skeleton. Okay. The cardiac muscles are involuntary muscles, and the muscles, basically examples are forming the walls of the blood vessel, intestine, and other hollow structures and organs. The third one, the smooth or visceral muscles, are muscles of the heart, and they are involuntary muscles. You can see here the pictures of different muscles, and of course one picture showing the structure of a skeletal muscle. The function of the muscles are to provide motion, maintenance of certain posture, human posture, and heat production. We'll focus more on the skeletal muscles because we are focusing on musculoskeletal structures and the biomechanics, movement science, and the relationship between structure and function. Okay. Now, skeletal muscles actually consist of several subunits or bundles called fascicles. Okay. So there are several subunits or bundles, muscle bundles called fascicles, and they are actually surrounded by some connective tissue, and each fascicle is composed of numerous muscle fibers or muscle cells. Okay. Now, these muscle cells consist of many fibrils or myofibrils, and these myofibrils are made up of long protein molecules called myofilaments. Okay, you can see some of this in this picture. Okay. Now, the skeletal muscles has bundles, and the bundles have some fibrils, consist of many fibrils, and these fibrils, myofibrils, are made up of protein molecules. So the skeletal muscles are usually attached to bone by tendons. Very, very important. There is another player who is coming into the picture now. Like we have several players in a football team, and everybody is doing certain duties and responsibilities. So tendons, as you might know colloquially, they are composed of connective tissue, and they are actually attached. The skeletal muscles are attached to bone with the help of tendons. Very, very important. Okay. So this connective tissue also draws the entire muscle and is called epimysium. Let us move to ligaments, which probably you all know very colloquially again. Ligaments are fibrous connective tissue that connects bone to other bones. Okay, so bone to bone. You can see here already. Let us consider this. This is a knee joint. I would place it like that. And you can see already the femur and the tibia. Okay, and if I rotate it like that, there is ligaments on the two sides which are connecting the two bones. Okay, so these are collateral ligaments. Very common injury of football players are ruptures of anterior cruciate ligament and posterior cruciate ligaments, which are crossing. Cruciate word means cross. So ACL and PCL tears are very common ruptures in highly demanding sports activities or physiological activities. Okay, so ligaments are very important players in the musculoskeletal system, and they connect bone to bone. Okay, and what connects muscle to bone? Tendons. Okay, so this is the essential difference between the function of tendon and ligament. So tendon is a tough band of fibrous connective tissue that usually connects muscle to bone and is capable of withstanding tension. Okay, remember all these tissues, basically soft tissue, we can classify them under soft tissue category. They act mostly in tension. They are like cables. Okay, so students from the technical world knows how cables work. They work in tension, not in compression. You see the cable stayed bridge when you go to Calcutta, travel via the second Hooghly Bridge. So all these members are in tension. They only act in tension, not in compression. Okay, so they are capable of withstanding tension. Tendons may also attach muscles to structure such as eyeball, and a tendon serves to move basically bone or structure. It is similar to ligaments, and all three are basically made up of collagens. The ligament is a fibrous connective tissue which actually attaches bone to bone and usually serves to hold the structure together and keep them stable. Okay, so stability, when I say keep them stable, so stability of a joint is provided predominantly by the ligaments. Okay, if we try to make a rigid body model of our musculoskeletal system, now we have to summarize it, try to bring the whole human body system and try to look at it from the point of view of a mechanical engineer or engineer as a whole. So we have anatomic element bone, which is sort of a rigid link. Okay, joints are standard joints. I will discuss about how the mechanical joints are related to the human joints, the relationship between the mechanical joints and the human joints. So standard joints are hinge joint, revolute joint, saddle joint, pivot joint. So these are all standard joints. The muscle and tendon, they are actually actuators in a mechanical system, and they are responsible for moving or controlling a mechanism or a system. Okay, so muscle and tendon together work together, and they are like actuators. Can everybody follow on the back? Okay. The ligaments, on the other hand, are controllers. So actuators are a type of motors. They help in moving and controlling a system, whereas controllers of springs are monitors, and they physically alters the operating conditions of a given dynamic system. Okay, they control the system. Controllers and acting as spring elements as well, the ligaments. So this basically is a summary of the analogy between the musculoskeletal system and a mechanical system as a whole. Okay. So next we are taking into consideration the joints. There are several types of joints in the human body, and we will look into the types, but we have to be a little bit quick because this will give you an overview of the different kinds of joints. Joints provide articulation, site for where two or more bone meet, and the joints are the weakest part of the skeleton. This is very important because this is the weakest link in the structure, because there is two or more bones are trying to meet, and there is a question of stability always in the joints. So we can classify these joints based on functional and function and the amount of movement that is allowed in this joint. So there are three types: immovable joints, slightly movable joints, and fully movable joints. So these are synarthrosis, amphiarthrosis, and diarthrosis respectively. Okay. So immovable joints, slightly movable joints, and fully movable joints. So we can classify based on structure. So there are fibrous joints, syndesmosis, and gomphosis. Okay, bone ends united by collagenous fibers. So if I look into the other classification, the cartilaginous joints. Okay, these are joints where the bones are united by cartilage. Okay, so within the cartilaginous joints, we have synchondrosis, we have symphysis, and we have the synovial joints. The synovial joints we will discuss more. Okay, but just let me show you some pictures about the fibrous joints. So we have the shooter. Okay, and you can see how it acts. So these are immovable joints. Next we have the gomphosis. Say, let us consider the tooth. Okay, so ligaments hold tooth in the bony socket, and these are immovable joints. Okay, they hardly move. Cartilaginous joints, slightly movable and immovable joints, both are there. So this lacks a synovial cavity. It actually, the bones connected by fibrocartilage or hyaline cartilage. Okay, so I will show you one example later on where you will see how these the examples of those type of joints. So here comes the examples of some of the immovable joints. You can see in the sternum, there is, if you look into the top of the rib cage, there is a sternum, and joint between the first rib and sternum is immovable joint. Okay. Then if you look at the pubis symphysis, this is little bit disturbed here. Pubis symphysis, the connection point between the two pelvic bone, see, is an important joint which is called pubic symphysis, and this is held together by very strong cartilage. So we have also band of fibrocartilage in the vertebral column. Freely movable joints. Let us now come to freely movable joints. So we have a knee joint, as you can see here, everybody, and this actually moves. Okay, can everybody see that? So this is an example of a freely movable joint, and most type of joints are freely movable, and each contain a fluid-filled joint cavity. Okay, so if you look here in the hip joint, here also there is a hip joint, and you have the ligaments which are holding this joint, femur and the pelvis. And if you look inside this joint, you can see that there is a joint cavity which contains a synovial fluid. Okay, and that is the reason why it is called synovial joints. Okay, so you have a fibrous capsule as well as synovial membrane, and this is a cavity which is of vital importance as far as the movement of or articulation of the joint is concerned. So here is example of synovial joints with articular disc. You can see the articular cartilage here within the joint, and you have a synovial membrane and then articular disc inside synovial joint, and this is all housed inside a fibrous capsule. Okay, so synovial joints actually contain articular disc. This occur in temporary mandibular joint and knee joint. So TMJ is a temporary mandibular joint and knee joint where you find the articular disc, and this also occur in joints where the articulating bone has somewhat different shapes. The general structure of the synovial joint, you have articular cartilage, ends of opposing bones are covered by hyaline cartilage, and this cartilage actually absorbs a lot of compressive load. Okay, so compression absorbs a lot of compression, and you have joint cavity. It's a synovial cavity which is unique to synovial joint. It is not present in other joints. So there is a cavity, and this cavity has a potential space that holds a synovial fluid. So articular capsule, the joint cavity is enclosed in a two-layered capsule. Within this structure you can see, and the fibrous capsule is dense irregular connective tissue that strengthens the joint, and it has a synovial membrane which actually lines joint capsule and covers the internal joint surfaces. Okay, and the functions, basically this synovial membrane functions to make the synovial fluid. So the synovial membrane has actually two functions. So it lines the joint capsule and covers the internal joint surface, and it functions to make the synovial fluid. The synovial fluid is a viscous fluid similar to raw egg white, and it actually helps in articulation of the joint. Okay, and this fluid is similar to mechanical engineering subjects. So the function is similar to the tribology, and it reduces wear and tear of the joint. So this viscous fluid has two functions: to filtrate of blood, and this arises from capillaries in the synovial membrane, and it contains glycoprotein molecules secreted by fibroblasts. Now the general structure can be summarized. General structure of the synovial fluid can be summarized as follows. So it has reinforcing ligaments, and it often are thickened parts of the fibrous capsule, and sometimes as extracapsular ligament located outside the capsule, sometimes as intracapsular ligament located internal to the capsule. It actually richly is supplied with sensory nerves, the synovial joint. It can detect pain and mostly monitor how the capsule is being stretched. Okay, so it has also a rich blood supply. So examples of synovial joints: shoulder joints, knee joints, as you can see. Temporary mandibular joints, a very complex joint, and it is subjected to different kinds of load, both mechanical loads as well as emotional loads. Okay, so and it is subjected to continuous use of chewing and biting. So the types of synovial joint, as I was telling you, the analogy with the mechanical joints, we have actually several types: planar joint, hinge joint, pivot joint, saddle joint, ball and socket joint, and condylitic or ellipsoid joints. Some of the examples are just listed here, and typically a knee joint is a hip joint, elbow joint is another hinge joint. We have a ball and socket joint in the shoulder, so this is moving, you can see the rotation, and also at the hip it is a ball and socket joint. So we will try to move fast with the hinge joint examples. We have a knee, elbow, ankle, and interphalangeal joints. This is example of hinge joint. We have a planar joint. These are joints which are mostly in the wrist and the fingers. Okay, so we have examples are intercarpal to intertarsal joints. We have sternoclavicular joint in the shoulder. Okay, the shoulder blade actually within the shoulder girdle, we have the clavicle connected to the sternum by the sternoclavicular joint. Pivot joints are sort of the radio-ulnar joint. Okay, so we have rounded surface of the bone articulates with the ring formed by the second bone and the ligament. So you can see this, the example is radio-ulnar joint. And the saddle joint is again available in the wrist and fingers. Okay, so the more the movement offered in the joint, the more is the mobility. So you can now just reckon this human skeleton that the upper limbs are actually providing more mobility but less stability, but the lower limbs are actually providing more stability but less mobility, because the more the joints, number of joints, the more the movements, the subtle movements you will get actually, but at the cost of stability. So the lower limbs provide you stability, less mobility. The upper limbs, you can provide more number of motions, more complex motions, like the shoulder, the lower part of the arm, and the fingers. The ball and socket joint, typical example is the shoulder joint. Condylitic joint again is visible in the finger joints. So wrist and metacarpophalangeal joints are example of condylitic joints. So the factors that are influencing the joint stability is the shape of the articular surface. So you can imagine that there are several types of joint with several articulating surface. The ligaments that actually are attached to the bones in the joint, and the muscle tendon unit that actually provide the most important stabilizing factor. Joint disorders are quite common, particularly with age and different problems and bone degenerative diseases. Okay, so we have a lot of osteoarthritic patients. 75% is provided with joint replacements. There are traumatic fracture, road traffic accident, and other types of injuries. Rheumatoid arthritis, which is an anti-immune disease, and there are other different kinds of sort of joint disorders. And you can see here that we will move a lot, we'll show a lot of these, about joint replacement. We will discuss a lot more, but here you can see a normal hip joint and a worn cartilage in arthritic hip joint. So it's an arthritic knee here, and you can see the joint space on the left condyle and the right condyle is different. You can see easily that the joint space have reduced, and the upper part of the bone is almost fusing into the lower part. So hip fractures. Treatments, arthroscopy basically is an examination of the joint where we put an arthroscope and try to repair with some specialist tools. And this is, the arthroscope has a camera and you can look inside the joint, and there's a video, so the clinician can actually enter inside the joint and try to detect or diagnose problems in the joint. Okay, but only small incisions are allowed. It's a minimally invasive surgery. Okay, the joint arthroplasty or the replacement is not a minimally invasive surgery. You have to actually, it's a major surgery, and the examples are total joint replacement. Here you can see on the left the hip joint replacement with a total hip, and there is a resurfacing procedure which actually replaces the surface of the hip. Joint movements. Okay, so what are the movements it offers? We have flexion, extension, which is shown here. Flexion, probably mechanical engineers know, because bending comes from bending. So basically flexion and extension are just opposite movements. And you know how to flex your muscle? Okay, it's when you show your power. Okay, so that means you're bending the muscles, and you can see here that you're flexing your knees and extending your knees, flexing your hand and extension, flexion and extension related to the upper limb, lower limb. You can actually do it also in the body. Abduction, adduction. Okay, so this is sort of abduction. When I raise my arm, so this is about 90-degree abduction of the humerus with respect to the shoulder. Okay, and I can go up to 180 degrees. For different patients, you might not get full 180 degrees abduction. Okay, and adduction is lowering the arm towards the midline of the body. And you have internal rotation and external rotation. That is when you are internally rotating your arm and externally rotating your arm. Elevation and depression, of course, you know that it's raising and lowering. Some special movements, of course, are there, which is related to specifically to a limb. So like pronation, supination. This is in the elbow joint. Okay, this is basically moving the bone inwards and outwards. It's connected with rotation. Come to the final slide is the gait analysis. As we walk into the world of biomechanics, we actually try to quantify human movement. And a walking cycle or a gait cycle has several phases. So two such major phases are the stance phase and the swing phase. As you can see, it starts with the heel contact. See, there are two legs, the left and the right, and both are actually working at the same time when you are performing this walking cycle. So it starts with heel contact, right heel contact, and you can see the cycle ends where it starts again at the heel contact. So, and this is basically toe off for the left leg. Okay, so if it is a right leg, heel contact, it's a toe off at the right. So we have these phases which can be actually expressed in terms of percentage of the total gait cycle, and you can see that there is the right stance phase, which is about 60% of the whole cycle, and 40% is right swing phase, whereas the left swing phase is about 40%, and at the same time the left stance phase is, you can see, is 60%. It's just the reverse. Okay, there's a lot of work which has been done with movement science, and I think Professor Verdonschot will speak on gait analysis separately, but this is a very important subject of biomechanics. Thank you very much, and welcome to the world of biomechanics. Welcome back to the second lecture of this Orthopaedic Biomechanics Implants and Biomaterials course. I will briefly focus on the concepts of stresses and strain, primarily sort of directed towards participants from disciplines other than mechanical engineering. Okay. So, as you can see from the first slide, that any specimen can be subjected to major loading conditions such as tension, compression, bending, shear, and torsion. Okay. So these are individual load cases, but it may happen that a combined state of loading, the specimen can be subject to combined state of loading. Now, when we apply load on a specimen, it can actually deform. But mechanics, the world of mechanics is basically based on two types. One is rigid body mechanics, another is mechanics of deformable bodies. So we'll focus more on the mechanics of the deformable bodies, because in rigid body mechanics we assume that the body is rigid and there is hardly any deformation. Okay. So we are considering deformation of a solid body. So when we apply load in form of, say, a weight here applied to a spring, it's actually elongated, and this elongation will depend primarily on the applied force. So force is proportional to the displacement, and then we can apply a proportionality constant, which later can be defined as the stiffness of the material. Physically, what we mean is the property by which the body can resist deformation. Okay? Stresses. Now, how do we define stress? Stresses are generated, not applied. Loads are applied, and when only there is, if I leave this pen here, there's hardly any stress. But if I try to pull it, then only, internal forces comes into play to resist deformation. And that is what is stress. So for a force on a solid, it is acting on an area. Okay. Now, very important consideration is stress always acts on area. Stress is basically a second order tensor. It has to be accompanied by the definition of the area on which it is acting. So if I consider stress, if anybody asks you that stress at a point, what is meant by stress at a point? You have to define the area, orientation of the area on which this point is located. So say there is a point on my palm, and if I try to orient the area in different orientation, the stress at this point will change. So there is nothing called stress at a point unless you specify the orientation of the area on which this point is located. Okay, and how you can define the orientation of the plane by the unit normal vector on the plane. Strain is connected with elongation. So strain is when we apply forces, the body deforms, there is elongation. So basically the elongation divided by the original length is basically the longitudinal strain, is defined as the longitudinal strain. Okay. So here you can see that epsilon is delta divided by L, the original length, and delta is the elongation, and this is a uniaxial load case. So there's the undeformed rod, and this is now being acted by uniaxial tension. So it is a measure of a fractional change, measures a fractional change. Okay, but this is longitudinal strain. Remember, there is a shearing strain which is connected with the angular deformation. We have Young's modulus. As you all know probably that every material has certain material properties, and one of the major aspect is the Young's modulus, that is defined by the elastic modulus. And when we actually apply loads or strain, we can measure the stresses. The stresses, load versus deflection curves can be obtained, and we can actually calculate the stresses. So stress strain curve during the elastic, in the elastic zone, we can obtain the elastic modulus. For inelastic material, beyond the yield point, actually the material undergoes some plastic deformation. So that is a deformation, if, even after removal of the load, there is permanent set in the material. So the material doesn't regain its original configuration in this zone. Okay. So in the zone where it is proportional, linear relationship between stress and strain, this doesn't happen. After removal of load, it goes back to its original configuration. Shear force. So this is just an example that when we apply a force on the top and the body is undergoing some amount of change in shape, not change in volume at this moment. It is actually the shape is changing, and you can see that there is an angular deformation, and this angle can be later sort of expressed, used to express the shearing strain. Okay, so this angle divided by the original length would give you the shearing strain. Okay, the angle delta x, this delta x divided by the L. So this will give you actually the shearing strain. Oh, just a moment. So we have, apart from the elastic modulus or Young's modulus, we have shear modulus. So shear modulus is shearing stress divided by the shearing strain. Okay, so shear force is acting on the top, as you can see, and it is acting on an area, and it is in plane. Here the shear is acting in plane. Okay, so the force is acting on this area will give you some shear stress, and with the shear strain you can actually calculate the shear modulus. Volume stresses can also be calculated when the body is subject to pressure from all sides. So there is a change in volume in the solid. You will see later on that a change in shape may be accompanied by a change in volume, or it may be purely change in shape, no change in volume. Okay, but volume stress is something, volume stresses and strain can be calculated as shown in the formula. Bulk modulus is volume stress divided by the volume strain. So these are situations where there is internal or external pressure, and the body is subject to sort of change in volume. Now we come to a slide where you can see some animations are there. So you can see here that what can happen to a volume of a material when we actually apply forces and constraint outside the body. Okay, so it can actually undergo some volume change depending on the loading condition. So this is contraction or dilation. It can, when it is subject to some shear, it will actually undergo some shape change. And if the body is executing some translation or rotation, if it is not fully constrained, then you can have change in position accompanied with change in orientation. Okay, so the combination of this actually can result in a new geometry as compared to the original geometry before loading. Okay, so depending on the loading conditions, the body can actually, there may be a change in volume or change in shape. So now let us see that what happens when there is some torque, okay, applied to a specimen. Here also you can see that it is accompanied by some shearing strain. Shearing strain is angular deformation due to shear forces. So we can summarize few things here. Very important that we can apply forces, not stresses. Okay, and stresses are developed within the body. Now, if we consider that there is shear stresses at the two ends of a specimen, we can see that inside the body, if we magnify a stress at a point, so if we consider this as a stress element, we can have actually complementary stress components, complementary shear stress components at the ends of this square element. Okay, so you may ask that why there are two sets. Okay, if you take moment about the center of this square, the whole square element must be in equilibrium. So that is the reason complementary stresses are coming into play, and it doesn't cause any sort of net moment inside the body. Okay. Now, as I said, that as depending on the orientation of the plane on which we are actually calculating the stresses, the normal and shear component of stresses can be evaluated. Okay, so please, participants from medical background or any other background, if you need more, you can clarify it later in the class or with your colleagues, and you can also come to me. So shear actually tends to change the shape of a body, and the body undergoes some level of distortion. Okay, so this was the original one. You can see already the shape has changed due to application of shear stresses at the two ends. Stress components. There are several notations. So the primary notation that I would like to highlight is, say, sigma, the stress. This is sort of, generally we use sigma for normal stress, and for shear stress we use tau. Okay, but generally speaking, we can say everything, we can start with sigma. So the first subscript is the plane on which this stress is acting. So it is acting on the x plane, so first subscript designates that. The second subscript is the direction. Okay, so if there is a stress, normal stress acting on this element in the orientation as shown in the figure, it will be x on the acting on the x plane and along the x direction. So if we can say that this is number one direction and number one plane, then it will be 1, 1. Now if it is upwards, then it is acting on the x plane but along the y direction. So it is tau xy. And if it is, if it is 1 and 2 respectively, then it will be 1, 2. Okay, so we can have actually a set of stresses in a systematic tensor in the normal material. So we have, say, a shear stress here, a complementary set of stress, shear stresses here, and this will actually give you this final orientation of the state of stress in the element as shown. So we consider a complex situation. and we are trying to evaluate what stress at a point. So let us consider a body, and it is subjected to a set of loading condition, loading and constraint condition. So what would it actually look like, the stress and the stress components at a point? So we have in 2D, 2D means plane, it is in plane stresses. So we have the normal stresses sigma xx, sigma yy, and shear stresses which are acting, which are complementary in nature, but they are in plane shear. There is no component which is of stresses which is out of plane, because this is a 2D case. So you have sigma 11, sigma 22 are the normal component of the stresses, and the shear are actually tau xy and tau yx. Okay. So you can see here the diagrammatic representation that this is sigma xx, this is tau xy, this is sigma yy, this is tau yx, and this is exactly replicated on the other edges of the square element. Now, as I told you that deformation of a solid can be accompanied by change in volume and change in shape. So if we try to write down the equations of, say, normal principal stresses acting on a body, we will have two basic parts. One is the hydrostatic part, another is the deviatoric part. Okay, so we have actually here the hydrostatic part, which is primarily the mean or the average of the normal stresses sigma x and sigma y divided by 2. But in the deviatoric part is the distortional part. It is the part where the change in shape is happening. So here the element is the shear stresses are acting to actually change the shape of the material. So this part is the deviatoric part. You can see here sigma m replaced by sigma x, x plus sigma y by 2 on two sides, and here the deviator. If you add this, this will be 0. The first invariant will come into play, and this is the shear stresses. So the diagrammatic representation are as follows. Just connect you to the world of biomechanics, example of some loading and deformation of the bone structure. You can see that this is tensile stresses, this is shear. So normal stresses due to tensile load, this is shear stresses due to shear load, and this is compressive stresses, and you can see the deformation due to the compressive stresses. Examples of loading and deformation of the bone structure explained very nicely by some stress element. Okay, if you consider stress element here in the metaphyseal region of the femur, you can see this is compression and how the change, how the stress element shape is changing. Okay, here also tension. Then the shear is actually distorting. The element is subjected to element distortion. Torsion ultimately translates into shear, you know, because when you do problems on torsion, you actually are taking shear stresses and shear modulus. When you do experiments to find shear modulus, you actually subject the material to torsion load, isn't it? And then bending. So bending also, you have normal stresses due to bending and shear stresses due to bending. So it is accompanied by change in shape and change in volume, both. Thank you for listening.
So you passively bring the patient's hip all the way up, and normal hip flexion range of motion is 120 degrees. Then while you're at 90 degrees of hip flexion and knee flexion, you can bring the patient into internal rotation. The patient bring their knees flexed to 90 degrees, and then they can cross their legs together, and you can compare each side, each leg, to see. First, you're going to bring, you would always test the uninvolved side first for comparison, and then you'll go to the involved side. So first, we're going to bring her hip through hip flexion. So you passively bring the patient's hip all the way up, and normal hip flexion range of motion is 120 degrees. First, you're going to bring, you would always test the uninvolved side first for comparison, and then you'll go to the involved side. So first, we're going to bring her hip through hip flexion. So you passively bring the patient's hip all the way up, and normal hip flexion range of motion is 120 degrees.
Yeah, okay. Okay, good morning, everybody. My name is Nico Verdonschot. I'm a biomechanical engineer. I work at the University of Twente and at the Radboud Hospital in the Netherlands. I'm going to talk about anatomy of hip and knee in relation to its function. So how does a biomechanical engineer look at the anatomy and the function of hip and knees? And since I'm from Holland, I start with a picture of Rembrandt van Rijn. He's a very famous painter. And this is the night watch. I apologize for the quality, but the night watch is one of the most famous Dutch things to visit if you're in Amsterdam, except for other things perhaps. So it is so famous that even President Obama went there to visit the painting. But Rembrandt also painted this famous painting, which is the anatomical lesson of Nicolaas Tulp. So this is an anatomical lesson. And so you see here Dr. Tulp doing, instructing the students. And I feel a little bit perhaps like this Nicolaas Tulp here. So, but I have to admit that I don't know everything. So maybe I'm also a student. And I hope I'm not the victim. Okay, so ask me anything you want, and we will get as much as possible out of this course as possible. So anatomy of joints relates to bones, the capsules around the joints, the ligaments, as Professor Gupta already indicated, and the muscles. Okay, so I'm going to talk about all these things. And the first thing we will focus on is the hip joint. So here you see the pelvic bone cross-section, and here the femur. You can see very nicely the trabecular structure, here the intermedullary canal, the epiphysis here. You can see here the joint with cartilage here, and there is cartilage here, and there is an open space here, which is for a ligament that attaches the femur to the pelvic bone, which is the ligamentum teres. I will show that later on. It also feeds with blood the femoral head so that it stays alive. Here you see the bones. You see here also the lesser trochanter, which I always look at if I have to know whether I'm looking from the front or the back. So the lesser trochanter is on the back side. Here you see a cross-section, so it's a transverse cross-section. So here you see the acetabulum, and here you see the femur, and you see the very nicely oriented spongious bone. This is kind of, from a biomechanical point of view, it's an optimized mechanical system. We don't want to use a lot of material for adequate strength. Okay, here you can see again the cavity for the ligamentum teres. What you also can see here is that this is cartilage, but there is not everywhere cartilage on the acetabulum. We will see that in a minute. You can see that here. There is an area, there is no cartilage, and you can see here the ligamentum teres, which has been sectioned for visualization. So this is an artery that feeds the femoral neck. Okay, so here you can see the cartilage. You can see the cartilage on the femoral head. And the cartilage has been extended. It's more than covering the bone. It's actually coming out of the bone. And that's the labrum. And some people have very stiff labrum, and that limits motion. And some people don't have that, and then they increase motion. This is, of course, a synovial joint, and the range of motion which permits is less than that of the shoulder.
but its strength and stability is much greater because it has to carry much more load. Okay. You can see here a picture, and you can see also that the capsule surrounds the joint completely. And you can also imagine that this capsule prevents motion if the capsule is irritated or is very stiff, or if there is too much fluid inside the joint, the patient will have difficulties of reaching the range of motion that the person wants to do. The head of the femur forms more than half a sphere, so you can see that it's more than half a sphere, and it's covered with hyaline cartilage, except for that area where the ligamentum teres is, and it's directed upwards, medially, and slightly forwards. I come back to that. Throughout the range of motion, there is about 40% of contact. Okay. The joint has an enormous amount of stability, and that stability, or we call it maybe in layman terms strength, depends on how deep the acetabulum is, and also the labrum, that extended cartilage that grabs hold of the head. So here you could imagine that if you have cartilage around the femoral, oh, I can show it better here. So if you have here the socket of the acetabulum, and there is, let's say, a layer of labrum that grabs around the head, it's more stable. Okay. So that increases the stability, and the strength of the hip joint is also increased by the ligaments. And it's very difficult to separate ligaments from capsule because the capsule consists of ligaments. So if I ask the surgeons from a modeling point of view, which ligaments should I simulate, they say, well, the whole capsule. So it's very difficult to discriminate that. And the stability of the joint is also depending on the length and the orientation of the neck of the femur. I will come back to that. Here we see some anatomical pictures of the capsule. You can see basically that it's all ligamentous structure. And this is the back side, and this is the front side. So this is from posterior, and this is from anterior. And the back side, you can see here again the minor trochanter. So that's why I know it's from the back. Okay, so here you can see the minor trochanter on the back side. And here you can see, and I listed here the number of ligaments that are surrounding the joints. And it's basically, it can be very stiff. And that's also why ballet dancers or people doing sports needs to stretch, because they need to make sure that if they do a sudden larger range of motion, they don't injure those capsular ligaments. These ligaments have to, of course, accommodate the range of motion. So you can see here, if you flex your hip, all the capsule, all the ligaments have to rotate with it, have to allow it, basically. And I have a movie from YouTube that shows how a physiotherapist or a surgeon will assess, this is first an animation of the range of motion. So here you see flexion, this is extension. Huh? This is internal rotation, and it is external rotation. Yeah. And this is abduction, and this is adduction. So the adduction is usually very small. So Professor Gupta already indicated how you can measure that, and I think I can summarize this by going to the next movie of an actual assessment.
First, you would always test the uninvolved side first for comparison, and then you'll go to the involved side. So first, we're going to bring her hip through hip flexion. So you passively bring the patient's hip all the way up, and normal hip flexion range of motion is 120 degrees. Then while you're at 90 degrees of hip flexion and knee flexion, you can bring the patient into internal rotation and external rotation. Normal is 45 degrees for both. Then while the patient is supine, you can stabilize on the contralateral ASIS and bring the patient into abduction. And when that contralateral ASIS feels like it's moving, that's the end of the range. Then you can bring the patient into adduction by moving this leg off the table, coming to the other side, stabilizing ipsilaterally, and then bringing the patient into adduction, just like that. To measure extension, you can have the patient turn prone. And you want to stabilize at the iliac crest. You can have their knee bent or extended. And you're just bringing them back up into hip extension. Now from this prone position, you can also have the patient bring their knees flex to 90 degrees, and then they can cross their legs together, and you can compare each side, each leg, to see their gross external rotation range of motion. And then you can have them separate their ankles to see their gross internal rotation range of motion. And that is how you can do a quick range of motion screen for a hip exam.
Okay, so this is how a clinician would assess the range of motion of the hip. As I said, we're also going to look at muscles, the activators of the body. And it's very difficult to indicate all the muscles around your hip and knee joints, which generate motion. And I thought I mentioned just the most important ones, which are hip flexors. And those are the psoas, which are actually connected to the spine, the ilias, and the rectus femoris, and the sartorius. And you would almost imagine that hip flexors or benders of joints, it's easy if they have an effect on only one joint. You know, it's like my biceps. It's very easy. But most muscles, or a lot of muscles, have biarticulate effects. Like the sartorius is connected to the pelvis and is also connected to below the knee. So they span the hip joint and the knee joint. So from a modeling point of view, that is very challenging because you cannot just increase the strength, for example, to have a better hip flexion, because you do also something with a knee extension in this case. Okay, so that makes it very challenging in simulations. The adductors, they make sure that the leg goes to the medial side, because that's called adduction. Those are the muscles adductor magnus, adductor brevis, and adductor longus. Okay. Abductor muscles are very important for walking. These are the muscles on the side of your body. Okay, the gluteus minimus and medius, and to a more limited extent, the tensor fasciae lata. So, for example, if you get a hip implant, sometimes they need to go. The surgeon will go through these muscles, and the muscles will be weakened, and the person have problems of walking up normal because his abduction power has reduced. Okay, then for hip extension, those are basically your, this is a gluteus maximus on the back side, so you're sitting basically now on it, okay? Also very important, but very strong. If you look at hip extension, so hip extension is, of course, to make sure that I'm upright, okay? Those muscles are on the back side, okay? So the hamstrings, for example. The hamstrings consist of the biceps femoris, the semitendinosus and the semimembranosus. And so they extend the hip, right? But these are also biarticular muscles, so they do also something to the knee, the hamstrings, okay? So difficult. If you look at the bones, it's important to know that what is normal. A surgeon or a clinician will always look what is normal. What is a normal range of motion? What is a normal orientation of the femoral neck relative to the axis of the femur? And normal is about 125. If a person or a patient has an excessive coxa vara, then the inclination angle, this is called an inclination angle, is lower, okay? And coxa vara, your varus, it means O, so basically it's more round, so you can remember that. Valga means more straight, so this neck angle is much smaller, and therefore the inclination angle is bigger, and this has consequences on the range of motion that a person can do, okay? It is also important to know that the orientation of the femoral neck and the opening of the acetabulum is not symmetric in the frontal plane. So I have here the synthetic joint. If this would be exactly if the socket would be open relative to the femoral neck, it would be symmetric, you know, so we could flex and extend as much. But we need to flex the hip more than extend. So therefore, the acetabulum is opened up. So this is on the right side. It's opening to the front. And the femur is also opening to the front. And therefore, I can move much more and I can rotate much more before the femoral neck hits the acetabulum rim, okay? So this is very important also in simulations because the rotation in this direction is much more than in this direction. And we need more internal rotation and also more flexion, okay? Now this is an example on a CT scan. And the surgeons will measure how much anteversion you have. Okay. Then I move to the knee. Professor Gupta already talked a little bit about the knee. It is important to analyze where the fibula is. This is the fibula. The fibula is on the outside, so that's on the lateral side. That's how you can immediately see whether you have what the lateral and the medial side is. So this is the lateral side. You have all kinds of ligaments, but the most important ones are the collateral ligaments and the cruciate ligaments, as Professor Gupta already indicated. You have the patella. Patella is sliding over your femur. And you have the patella tendon. And this is the tendon that connects the quadriceps. Okay. And then you have here the meniscus. You see here the cruciate ligaments. This is from the frontal view. And this is the anterior cruciate ligament. And here, you can remember this is the anterior cruciate ligament because it's connected on the anterior side of the tibia. The cruciate ligament is connected on the back side. Okay, so this is anterior and it's connected on the lateral side. Oh, I know that because this is the lateral side. This is the fibula. Okay, this is cartilage. You can see that the cartilage is not symmetrical, whereas prosthetic implants are a lot of them are symmetric. So there needs to be, you engineers can do something about it. You can see here the patella gliding in the groove. Okay, and this is the medial meniscus and the lateral meniscus. So again, this is the medial meniscus. This is the top view on the tibia. Okay, medial meniscus and the lateral meniscus. And this is the ACL, where the ACL connects, and it's going to be connected here, like here on the lateral side. Okay, here you can see the lateral meniscus. We'll talk tomorrow about menisci. Here you see another specimen. This is the lateral collateral ligament. This is popliteus tendon. And although I show you this, you have to remember that the knee is completely surrounded by a capsule. We as engineers think about these ligaments, but it's all around it by a capsule. The flexors of the knee are exactly the same as the extensors of the hip on the top side. And if you look at the flexors of the knee on the bottom side, that's your calf muscle. Okay, so the gastrocnemius primarily. You have a medial and lateral gastrocnemius. They make sure that you can flex your knee. For extension, of course, of your knee, the quadriceps is important. Okay, quadriceps consists of 4 quadriceps. Quadri is 4 muscles, which is the rectus femoris, the vastus intermedialis, lateralis, and medialis. Okay, so they make sure that you can extend your leg. If we go to the ligaments, you can see here an animation which is just for educational purposes. You can see that these ligaments are stretched up. So this is a varus valgus. So if you force it in varus valgus, these collateral ligaments do their duty to stabilize the joints. Okay. So these are the medial and lateral collateral ligaments. To show the cruciate ligaments, I think this is a nice animation. These are the cruciate ligaments. This is the PCL, the posterior cruciate ligament. This is the anterior cruciate ligament because this is anteriorly. Okay, so the ACL does not permit the tibia moving forward. Okay, because then it's stretched, and the PCL does the other way. So you can look at this animation again. So this is simplified to 4 ligaments. Currently, models are now including more the capsule. So you see also that the collateral ligaments, they have some function in anterior-posterior movement, but primarily it's the cruciate ligaments that take care of that. So it's now to the front, and then the PCL is stretching. Okay. So if you can imagine that a surgeon can assess by moving your leg whether one of the ligaments is ruptured. That's also what they do. So I have here another movie, which is with sound, and she will test the ligament stability.
Often medial and lateral instability is tested at full knee extension and 30 degrees of knee flexion. However, the test at 30 degrees flexion is not reliable for osteoarthritis. I am testing for instability at 0 degrees with the ankle under my arm and the thumb on the joint line. Now, to test for medial instability, which really tests the integrity of the medial collateral ligament, I apply a valgus stress and look for a gap over the medial joint line. To test for lateral collateral ligament stability, I apply a varus stress and look for a gap over the lateral joint line. To test for anterior and posterior instability, I put the leg in 60 degrees of flexion, and I make sure that the patient's knee is relaxed. You can tell when the knee is relaxed, when the hamstrings are not tight in the back of the knee. And you can only do this test with relaxed hamstrings. So the anterior cruciate ligament integrity is tested with the anterior drawer test, where you pull the tibia forward and look for movement of the tibia in relation to the femur. And you can see that there's actually forward movement. So the anterior drawer test is positive. Posterior drawer test tests the posterior cruciate ligament integrity, where you push the tibia back in relation to the femur and watch for movement, and there's none. The other way we can assess for posterior cruciate ligament integrity is to put both legs up to 90 degrees, this one too. So for the posterior sag test, we place the knees at 90 degrees and look for posterior sagging of the tibia in relation to the femur. And we can compare sides, and there's no posterior sag here.
Okay, so that posterior sag in the last assessment, if you bend your knee, your posterior cruciate ligament pulls the femur backwards. So if your PCL, if the posterior cruciate ligament is not active, the femur remains to the front. And then she compares left to right, and she sees that both knees are moved to the back. She says she didn't see any difference, and therefore she knows that the PCL is intact. But she saw that on the right side the ACL was ruptured because there was too much play to the front. Okay, so this is the ACL, and to make it more complex, the ACL does not consist of one fiber. So, and in the modelers, the biomechanical modeling, we assume that the ACL consists of two fibers. And the two fibers have different insertion points, and that has an effect if you bend your knee. So this is in extension, this is in 90 degrees of flexion. And if you have two different bundles, you can imagine that the two different bundles become active at different flexion angles. So this is the anterior medial bundle is active at 90 degrees of flexion, but the posterior lateral bundle is not active. You can see it's slack. So that has consequences for the modeling. Okay, so I have here an animation of an ACL reconstruction, how a surgeon is doing it. So
Immersion media, next generation training and instructional media. Years ago, a torn ACL was a career-ending injury for an elite athlete. With advances in technology, surgical procedures, and rehabilitation, however, an elite athlete now has an excellent chance of returning to high-quality sports participation. To keep the joint stable, a set of 4 ligaments keeps the knee in a hinge-like position while you move. 2 ligaments on either side of your knee joint, the medial and lateral collateral ligaments, connect to either side of your femur and tibia and limit shifting movement left or right. The other 2 ligaments, the anterior and posterior cruciate ligaments, connect from the base of your femur to the top of your tibia. They cross each other and prevent the knee from excessive forward and backward movement, as well as twisting movement in either direction. If a movement is forceful enough, any of these ligaments may snap, including the ACL. Once torn, the ACL cannot regenerate or repair itself. The ACL reconstruction operation is now typically a 1-hour outpatient procedure, performed successfully more than one way. We'll examine one of the more common methods used in ACL reconstruction. The entire surgery is completed through just a few tiny incisions. One is made for the insertion of a tiny camera and to deliver fluid to establish a clear view of your joint. 1 or 2 additional incisions are made on either side of your kneecap to give the surgeon access to your joint. 1 very small incision is made to anchor the new grafted ACL in place. To start the procedure, the surgeon will insert a probe to inspect the damaged joint. A small motorized shaver will then be used to remove the damaged ACL and prepare the area for the new one. In every case, a surgeon will also inspect the entire joint to determine whether there is additional damage warranting other repairs. Then, the surgeon will use a device called a retroflip cutter to create a tunnel through the femur and into the knee joint. The surgeon will also create a tunnel through the tibia and into the knee joint from below. These two tunnels become the source of the anchor points for the ACL graft. In most cases, the surgeon will harvest a portion of your own hamstring tendon to use as the graft. Using your own tissue reduces the likelihood of your ACL rupturing again, and is a reason some surgeons decide not to use a tendon harvested from a cadaver. A surgeon will harvest more hamstring than needed to avoid the challenge of not harvesting enough. To the patient's benefit, hamstring tendons consistently regenerate over time as well. Your surgeon will prepare the harvested hamstring and pull it through the upper hole and into the lower hole just taut enough to mimic your original ACL. A small grappling hook will anchor the upper end of the graft, and a screw will stabilize the lower end. The screw is usually bioabsorbable, meaning your body will incorporate it into the bone over time. The graft from your hamstring tendon will act as a scaffold upon which a new ACL will grow. Over time, the hamstring graft undergoes changes and is strengthened, leaving a strong, viable ACL.
Okay, so this, you saw that they used an aiming device, and that's because they know where in the knee they want to attach the ACL, the anterior cruciate ligament. So they know where the insertion is, but then they need to know how to drill it. So they have this circular aiming device, which makes sure that, so from inside they focus on that point, and they can then drill from outside with that aiming device, and they know exactly where they will end up building, creating that tunnel. The tunnel is 1 centimeter in diameter, so it's quite a big tunnel for me as an engineer. I don't like big tunnels for bone strength, and so I think maybe we can make something more elegant, but nowadays they use a 1 centimeter tunnel. So, so we talked about exo-rotation and endo-rotation. Okay, so an endo-rotation typically means that you endo-rotate, so you internally rotate your foot, so inwards, relative to your femur, and then you can rupture the ACL. And usually, so this causes ACL injury. Usually we as engineers talk about how to reconstruct that, but in practice, this damage also damages the cartilage. You know, such an injury damages the cartilage and the meniscus. So here you can see the meniscus, and you have different types of injuries in your meniscus. So different cracks, fissures. And I'm going to show you after this animation, which looks very neat and clean, I'm going to show you a video of an arthroscopic surgery. And in that surgery, the surgeon will also take care of the meniscus tear. And the meniscus tear looks like a bucket handle tear, which is basically, it's not on the outside, so there's not a crack, but it's like a fissure inside the meniscus, okay? But the patient has complaints about that. So he will do an ACL and a bucket tear reconstruction. It's 4 minutes.
Surgeon, subspecialty board certified in orthopedic sports medicine. ACL injuries are among the most common knee injuries requiring surgery. Today's case demonstrates the reconstruction of a torn ACL in a young soccer player, along with the repair of a torn medial meniscus. The patient is examined under anesthesia. Both Lachman's test and pivot shift test are grossly positive.
So he's checking
The
again.
patient is then
There's an
prepped and
ACL
draped for
problem.
surgery. The arthroscope is inserted through a small lateral portal, and the knee is systematically examined. In this case, a prominent bucket handle tear of the medial meniscus is noted, along with a torn ACL. The bucket handle tear is addressed first and is reduced with a dull probe. An accessory medial incision is made to allow for safe passage of sutures through the tear. The periphery of the tear is debrided with a shaver to improve healing. Multiple vertical mattress sutures are passed, securing the tear in an anatomic position.
So he's basically sewing the meniscus
The sutures are
together.
then tied over the medial capsule and cut. The graft, in this case an Achilles tendon allograft, is prepared on the back table.
So this is not from the patient himself, but from a graft, from a donor. Okay.
Attention is directed back to the torn ACL. The torn fibers are removed using a shaver. A guide pin is passed from outside to in through the anatomic origin of the ACL from the femur and out through the skin laterally. A 10 millimeter drill corresponding to the diameter of the graft is drilled. Bone reamings are flushed from the knee, and a looped suture is pulled into the femoral tunnel and stored for later graft passage. The tibial tunnel is now prepared in a similar fashion using a guide pin and a 10 millimeter retro drill. The stored suture loop is pulled out of the knee and is used to pass the graft. The graft is then firmly seated in the femoral tunnel and fixed alongside the bone block with an interference screw.
So this is the tibial.
A second screw is used to secure the graft in the tibial tunnel after tensioning the graft. The final reconstructed ACL is palpated with a probe and found to be in excellent position and under appropriate tension. The small incisions are now closed in routine fashion and sterile bandages are applied. Rehabilitation consists of immediate range of motion exercises and application of ice to control swelling. Crutches and a knee brace are generally used for the first 6 weeks. Once range of motion is reestablished, strengthening exercises are begun and continue for several months. Full return to sports is generally allowed between 7 and 9 months after surgery.
Okay, so this was the first part of my lecture, and you see how difficult these surgeries are. And from a modeling point of view, there are so many limitations that we have relative to the actual situation. But I think we come closer and closer to actually simulate what happens in the body. So thank you for now, and I'm going to prepare for the next lecture. Yes, good morning. I give this talk on bone, the basics of bone. I want to acknowledge my colleague Jasper Hommiga, who works at the University of Twente, with whom I made this presentation. We're going to talk about bone, and it has some overlap with what Professor Gupta told you, but I think that I look at it from a different perspective. So I think extra information from a different point of view is, I think, good. So we'll look at function, anatomy, developmental bone biomechanics, and mechanical properties. We'll look at stiffness and strength. Okay. First, at function. And of course, we discussed already the function. It's protection of the essential organs. It's to enable movement and a calcium reservoir. So especially this area protects the essential body parts, let's say. And of course, the bones allow movement. If you don't have bones, you can move. I mean, snakes and snails, they move, but not as efficient as we do. So bones are good for efficient movement. And of course, the bone is a supplier of calcium. At anatomy, you can look at bones from a very different perspective. And if we look at it from a very detailed perspective, we know that bone consists of collagen, and on the collagen there is hydroxyapatite crystals. And the collagen makes the bone very tough, and the hydroxyapatite crystals, they make bone very stiff and maybe strong under compression. And collagen makes sure that it's under tensile more strong, okay? So it's a biphasic material, which is very smart. Our body is, of course, very smart. When you look at it from a macro perspective, we can see this categorization of bones. So you have an osteon. This is an osteon, this unit. And the unit of an osteon is formed by vessels. Yeah. They need to supply, of course, the oxygen to the cells. We see osteocytes. I will come back to that later. We see that the blood supply has also cross bridges, which are called Volkmann's canals. But you can see that it's kind of a tube-like structure. These osteons are tubes, basically. And there are cells around it which are depending on this nutrition, yeah, from the vessels. So here you can see again the tube from the top side. It's an osteon. It's osteon. And here you see the vascularization. And you can see here in purple there is an osteocyte. Yeah? And the osteocytes are the sensors in the bone. And they are connected with canaliculi to each other. So this osteocyte can communicate with this osteocyte through these caniculi. And these caniculi are very tiny tubes through which fluid can flow up and down. And the idea is that if you bend your bone, the fluids in those tubes move, and the osteocyte can pick that up. And then they know, oh, there is bending. I need to make bone, because if there is a lot of bending, I need to make bone. If the osteocytes don't feel a lot, they don't make bone, and then the bone disappears. If you lie in bed or if you go into space, osteocytes don't feel anything because there is no fluid, and then the bone will resorb. Okay, so osteocytes are very important. That's at least now the theory. So here you can see that it's built up. So this osteon is of course part of the whole bone. And if you look at the femur, for example, you have different areas. So the diaphysis, the epiphysis. This is the proximal side, that's close to the body. Proximal is close to the body. Distal is far away from the body. The cartilage, of course, here and on the condyles. You have compact bone on the outside and more trabecular bone on the inside. We know that now, huh? There is marrow in it. This is the red marrow that Professor Gupta talked about. There's yellow marrow, it's almost empty in the intramedullary canal. And here you see the epiphyseal discs, which were the growth plates once. And the periosteum. Here, periosteum is basically covering the whole bone. And the periosteum is very important because if you fracture a leg, the periosteum is damaged. And the periosteum has a lot of stem cells, original cells. And then these cells make sure that the fracture is healed again. So, and they come from the periosteum. So if you have a multiple fracture, you have a traumatic, very traumatic accident, and the periosteum is gone, you have a big problem to get that fracture healed again. Okay? So we look at the developmental bone. So this is our bone in mature state that I just showed you, but we start with really being only cartilage as a fetus. You only have cartilage. It's very flexible, of course. And at some stage, it starts to ossify. So this is a calcified cartilage. And actually that also happens in fracture healing. So if you have a fracture, first there is a kind of a cartilage layer. And from that cartilage layer, then there is going to be ossification. Okay, so that front of ossification increases, and that is how the bone grows, and this is then turned into bone. Okay, so you have here the growth plate still, and here you see also still the growth plate, so this person is not mature yet. And then finally you lose the growth plates, but you can still see them in a cross-section. Here used to be the growth plates, okay? The growth plate you can also see if you make x-rays, of course. So this is a 3-year-old child. This is a mature person. You can see here that there is still space between the bone and this type of bone, and therefore the bone can extend and grow. Okay? So this then becomes longer, and you see at 7 years there is still a growth plate, but it's already diminishing. And here at 19 degrees, the growth plate has gone, basically. And from the growth plate, basically the growth plate consists of cartilage type of cells. And there is continuous cell division, so cell generation, and these cells, the chondrocytes, they ossify, and that's why you can grow bone, okay? And then you have calcified bone. So you start with cartilage, very flexible in the fetus, but also in fracture healing it's very similar. We learn also from the field of embryonic analysis in fracture healing, and then you can optimize the fracture healing procedures. As I said, the periost is very important. So this is, for example, irritation of the periost, and then the periost generates bone. So this could be a person that does very long marches, and then you get, you know, this type of X-ray and thicker bones because the periost is getting irritated. Mechanical properties of bone. First of all, Professor Gupta already indicated, we talk about properties in engineering terms. We usually call it megapascal, and a megapascal is 1 Newton per square millimeters. Professor Gupta indicated that 1 Pascal is 1 Newton per square meter. Okay, and a gigapascal is 1,000 times more. Okay, so mega is a million, a giga is what is it? A billion. So if you look at stiffness for bone and relative to concrete or wood, you can see that concrete is more stiff. We can feel that. If you look at the strength of bone is actually stronger than concrete. So this is not iron reinforced, but just concrete. In tension, bone is stronger, and that's because of the collagen in it. Because the hydroxyapatite is not so strong. The calcium is not so strong if you pull it, but it's the collagen. And the weight, of course, concrete is the weight is higher. Okay. So if you look at the stiffness, bone is not isotropic. So its mechanical properties depend on the direction. So in the long axis, bone is very stiff. In the circumferential and the cross-sectional direction, it is less stiff. It's about a factor of 2 almost. You see that? And that's, of course, because of the function of bone. It's mostly compression. So it has to be strong in that direction, but less in the other directions. And our body has optimized that. It doesn't make sense to make it super strong in all directions if you don't need it. So we say bone is not isotropic, but it's anisotropic. Okay, and that bone is stronger in that direction is also because the osteons, that tube structure, is in this direction. Okay. Now look at trabecular structure, because I was earlier talking about compact bone. This is trabecular bone. That depends on the orientation of these trabeculi, of course, but it can be also a factor of 2 different, or even more. So the stiffness is lower than compact bone, so it depends on how you look at it. And people make micro CT scans to analyze that, the exact structure. I'm sure that some people of you do that as well. And they get these nice pictures. So this is not a big CT, but a micro CT with a resolution of 10 microns or so. And you can see how the bone is oriented and what the volume fracture is, whether it's very dense bone or maybe porous bone, what the architecture is, what the orientation of the struts are, and what type of tissue it even is, so the quality of the trabeculae. Okay? And bone also responds in a rate-dependent fashion. So it means that the stiffness and the strength depends not only on the density. If you make it very dense, it's of course stiffer. If you make it dense, it's stronger. But it also depends on the strain rate. So, for example, if you go downhill skiing, it's super fast, then the bone will respond as being stiffer and stronger, because this is then a higher rate. This is called a strain rate. So the strain, so the deformation change per second. And if you go skiing and you hit a tree, it's going to be very fast, right? Okay, but with elderly who fall very slowly, the bone will respond in another way. So there's strain rate dependency. A lot of engineers do not include that. And in fact, in our laboratory, we don't include that. Okay? So we have looked at strength of the compact bone, and so we looked at stiffness, and this is about strength, which has also depends on the orientation, but it's not a factor of 2 anymore. For the trabeculae, it's more than a factor of 2. You see that? It's a factor of 5 suddenly for trabecular structure. So now we talk about strength. We used to talk about stiffness. Huh? And I highlighted this graph already, and I showed you that the bone, the compact bone, is very strong. But it's also very ductile, and I will show you what it means. It means that it's a kind of a crack stopper. So if you have a crack in your bone, if you have a normal brittle material, the crack will just propagate and will fracture everything. And the bone is smarter than that. And that's because of 2 reasons. First of all, it consists of collagen and calcium. So there is a crack coming, and it hits the collagen, which is very flexible, and the crack doesn't penetrate that because it's kind of damped by the collagen. Okay. And the other reason is that it is this tubular structure in total. So there is a microscopic and a macroscopic effect of crack stopping. Because if a crack comes here, well, I can show that here. So if a crack comes here, the crack hits this tubular structure, so the tubes are now oriented like this, And then the crack has a preference to propagate along the tube. So it diverts the crack direction, basically, because of the tubular structure. Okay, so it's a microscopic and a macroscopic crack stopping material. And that makes it also very tough. All right? It arrests cracks. Some people have diseases, so osteomalacia, you have then a problem with the mineralization. So basically the bone matrix is defective. So you only have the organic phase, which is the collagen. And you can imagine there is some bone, you can see it on an X-ray, but the tensile and compression strength is very small. So these people really have a problem. Okay. Osteogenesis imperfecta is another problem, and that's a defective collagen. So that means the collagen is kind of absent, and it means that the bone is very brittle because the collagen is not there. So under compression, it is kind of still okay. It's only 30%, but in tension, you use your strength. Okay, so this is just a picture of a movie of a guy who had osteogenesis imperfecta. Okay, so in that sense, the mechanical properties are highly affected by the microstructure of the bone. And if something is wrong with the microstructure or the substances, mechanical properties are affected to a large extent. And then you need instruments like this. Like this is a nail that allows people who have osteogenesis imperfecta to function, because otherwise they will very easily break their bones. This is what orthopedic surgeons then do to strengthen it. Okay. Now this is my last slide of this talk, and I thought it would be nice to look at how nature applies these properties. So, and you see here an antler, a femur, and an inner ear bone. The task of an inner ear bone is, of course, to propagate the sound. So if you look at stiffness, the inner ear bone is the stiffest bone we have because it has to propagate the sound. If it's very flexible, the sound is gone. It damps all the sound. If you look at strength, the bone has to carry the most load. So it is 100% relative to the others. Of course, this also has to be strong, antlers. But if you look at fracture energy uptake, the antlers are much stronger than the femur and the inner ear because its function is to absorb energy in the fight with others. So it can uptake a huge amount of energy before it fractures. Okay, that concludes my presentation. Thank you very much. So what is the time? 3/4. Mm-hmm. It's longer. Okay, so we do metastatic. Okay, I think it will take half an hour. So that means that we are finished at 1/4 past. You prefer? Okay. 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 Yeah. Okay. Yeah. Okay. So
Small change because of some emergency situations. The lecture 6 is metastatic bone resection. That is shifted now, and the bone remodeling will be done tomorrow. Okay, because he has to go to the register. There's some very acute situations for that. So the lecture on bone remodeling will be shifted tomorrow. Okay. And after finishing this lecture, will be a bus here outside. We take a bus and then drop you in your halls and guest houses. And then you can go through. But remember one thing, this GAN course, we are giving you some material. You have to also study. You have internet connections, things like that. So here there will be sort of set of lectures, but you go and study. that is the purpose of the course. It's not just restricted to a few lectures. So we have a small shape, see that moderated shape because of this.
So do we have any questions about bone? Yeah. In global applications, if you want to show stress shielding. Okay, so the next presentation is about prediction of fracture risk in femora with metastatic lesions. And I would like to acknowledge my co-authors of this research. Luce Derks is the PhD student who just graduated, and she has basically done all the work. And we do this study with another number of hospitals and research institutes. So it's a multi-center approach. And the clinical background is that cancer is, of course, a world-leading cause of death. And you can see that the number of cancer patients increase in time over the last decades. What we also see is that people dying of cancer is actually reducing. So we are more and more able to treat cancer or to keep people alive with cancer. However, therefore there is an increased cancer-induced complication rate. So if people die with cancer, there is no complication. If people live long with cancer, there are all other things that we need to manage. So there are complications. And one of the complications is metastasis. And a metastasis is basically a weakening of the bone. So here you can see that a cancer, it can be lung cancer or kidney cancer, has extended to the femur, and there is basically a hole in the bone. From a mechanical engineering point of view, it is a hole in the bone. And 35 to 73% of the patients will get that. And the femur is mostly affected, although the spine, the vertebra, are also heavily affected. So there is an increase of risk of a pathological fracture. Okay, and the treatment is either we see that the bone is so weak we need to do something about it. So the surgeon, an orthopedic surgeon, will put a plate to make it stronger, or they will do radiotherapy, so radiation, if they think it's strong enough. So the question now is, we need to assess how strong the bone is with that metastatic lesion, and the people don't know. They just don't know. So if you assess that, there is now a clinical guideline, and it's a Dutch guideline, but it's internationally accepted, that if you have a cortical disruption of bigger than 3 centimeters, you should operate. So if this is a cortical disruption, you can see that here. You see here the cortex. This is compact bone, and here you see that it's thinner. And if this is longer than 3 centimeters, you should operate. You can imagine that it is very important to also assess whether it's here or on the lateral side. Yeah. If it's on the lateral side, there is at least an effect on the strength, because lateral or medial, there must be an effect. The surgeons cannot look at that. If it's on the frontal side, they just check the 3 centimeters, operate or not. So there is a problem, and they make many mistakes with the fracture risk assessment. So the aim of this whole project is to develop a patient-specific finite element model to improve the prediction of fracture risk in metastatic bone disease. So we're going to make a model to predict how strong the bone is. And we did that through different aspects. So we develop a finite element model, that's that calculation model. We do a validation, because every model needs to be validated before we can use it clinically. And there are certain aspects that we need to have a realistic material behavior. We need to have realistic loading conditions. And then we can simulate patients, and we check how these patients are doing clinically. If we predict bone fracture and they don't fracture a bone, our model is not right. Okay? So we develop a finite element model, and we do this by using CT scans. So here you can see a number of CT scans. And we do the segmentation of these bones. Okay, we only focus on the bone. So here you see the bone shape. We orient that bone, and we make a model of that. So here you should be able to see that the bone is now consisting of a large number of elements. It could be maybe 10,000 elements. You could make it more accurate by making a million or a zillion elements, but then the computer power goes up. So we need to compromise between the accuracy and the computational power. Okay, so we make a model, a geometrical model of this. What we also get from the CT scans is the density. So here you can see a cross-section of the model, and you see here the mechanical properties of bone within the model. So red is the cortex bone, the cortical bone, and blue is the more cancellous bone. We know the strength and the stiffness of these materials. I just explained that to you. So we can put it also in the model. Okay. What we don't see is the collagen. So we are working towards seeing also the collagen to be implemented in the model. But for now, this works quite nicely. So we have a distribution, and we put it also in the model. So we have the geometry, and we have the stiffness and the strength properties in the bone. Okay, so if there is a big hole in the bone because of a metastatic lesion, the CT scans will pick it up, and it will also be picked up in the material properties, because locally the bone density will be very low, and we will simulate a hole in the bone. Okay, so this is then that bone model, and we can simulate a fracture like here. Yeah. So you can see here that the material becomes plastic because we load it beyond the yield strength. And if it becomes plastic, you can imagine if so first one element becomes plastic, and then that kind of crack propagates through the whole bone, simulating a patient that ends up with a fractured bone. Okay, so now we need to validate that model. And we did that by using cadaveric bones, and we made all kinds of holes in the bones, and we tested them, and we simulated the strength of these bones. So we do all kinds of tests, and we simulate that. And we also gave x-rays of these bones to the clinicians and asked them, can you rank the strength of the bones? Yeah. So which bone is very dangerous, and how strong is the bone? Okay, so this is a movie of how we test then the bones. So this is an intact bone without a hole. This is a bone here that has a lesion here. So we determine the strength of the bones. What you also saw, so we determine also how it breaks. You can see here it breaks through the metastatic lesion. What you also saw is some red threads. So we also measure the deformation of the bone with strain gauges. I think the engineers know all about strain gauges. So you can glue on the bone sensors, and if the bone deforms, it becomes longer on the tensile side and shorter on the compressive side. And the sensors will increase their length or decrease their length, and depending on the length change, the resistance, the electrical resistance changes, and then you can pick up whether it's elongated or compressed. And by knowing that, we also know whether the mechanical properties of our model match up with what we've seen experimentally. Okay, so with strain gauges you can validate the deformation, not the strength. You cannot measure the strength. We measure the strength by the total amount of force registered by the machine. Okay, so we have here, we also do rotational experiments because we know that rotation is also important in terms of bone strength. And you can test it in many different ways, but this is how we did it. And it doesn't really matter whether the loading condition is exactly like clinically, as long as we know that we can simulate it exactly, because that is necessary for the validation. So the validation, we need to know exactly what we did in the experiment, and we can simulate it exactly. And later on, we are going to take care about the clinical loading conditions. Okay. So what we saw is for these 10 bones, but we have done more bones, is that this is our finite element model. The strength. So this is what we predicted, and this is what the model predicted. So we made one mistake here. If you look at what the experts did, so we asked six experts to rank the bones in terms of strength, just rank them, which one is the strongest. You can see that they can't do that. And the most important thing that they couldn't assess is the overall quality of the bone. They don't take that into account. They see a hole and they think, oh, if it's big, it's weaker. But if you could have a very strong bone from a young man with a big hole, which is much stronger than a small hole in a old lady's bone. And clinicians have it's very difficult for them to incorporate that, whereas we have that in the model because we get that from the CT scans, right? Okay, so we were quite happy. At least we are better than the clinicians, and that's always good to know. Sorry for the medical students here. Okay, so we have a validated model, and then we said, okay, so is it realistically also fracturing? And then we thought we could improve on that. So this is a complex graph in which we simulate how bone fails. So this is the displacement and force curve of bone, and Professor Gupta already showed that to you. So this is the stiffness. So if you put more stress on something, it deforms more, right? So this is linear up to a certain level. If you pass the yield stress, the material will basically plastically deform. So you don't need extra stress, but it will elongate. Okay, so it elongates, and if you pass then a certain threshold, it even becomes weaker in its resistance to elongation. So this is really, yeah, yielding. So here it's beyond this point, it's yielding. Okay, so this is when you apply a tensile stress and it deforms in a tensile direction. In compression, it is exactly the same behavior. Okay, so because it looks symmetric. In reality, we know that bone is weaker under tension than under compression. Okay, so it can uptake maybe twice the amount of compression before it starts to yield. Okay, and of course, I did not put any numbers here, like 10 megapascal, because it depends on the density in the bone. So this graph is scalable depending on the local density. For a trabecular element, it will be very weak, but for a compact bone element, it will be very strong. So the parameters used in this model will depend on the bone mineral density that we have in the model. Okay? All right? So if we simulate that, so this is a symmetric yield criterion. This is just for Mises yield criterion. This is called the Drucker-Prager yield criterion, which they also use in soil mechanics. Soil is, of course, also much stronger in compression than in tension. If you use an asymmetric Drucker-Prager yield criterion, you can see that the fracture looks a little bit more similar than in the yield criterion if you use a symmetric yield criterion. Because we found that a lot of bone was failing under compression, whereas typically bone fails under tension. Okay? Okay? Now you can imagine you can play around that with that as an engineer to make it better. Okay, so we have a more realistic material behavior. Then going to the more realistic loading condition. And what we used in our model is a very simplistic axial loading condition like I showed in the machine. And we use that for all our bones. And that's of course not what you find if you move around. So we can develop musculoskeletal models. So we have here a model, a rigid body model, including all the muscles or most of the important muscles. And then you can apply a much more complex loading condition to the bone. Yeah, it becomes now very difficult because we know that this muscle activation depends also on the person. So actually, at this moment, we are not sure whether this is less accurate to simulate patients than this, because you can make it more complex, but the complexity also includes more uncertainty. Yeah. But this is what we try to do now. So what we have done is we use motion capture of people walking and standing up from a chair, And then we can apply those loading conditions to musculoskeletal models. And now my computer is giving up. Oh. I didn't have that problem earlier. Okay, so now we are currently applying this method to a patient cohort. And that's why we work together with these clinical institutes. So we do a pilot study. So we work with 3 hospitals, and we included 66 patients with painful metastatic lesions in their femurs. Okay. Okay, and we follow them up for 6 months. 6 months is the average time that patients live after metastatic cancer in our cohort. So I'm used to doing orthopedic, implants, and it's very relaxed and interesting. But these patients they really require the highest quality of life in the remaining lifetime of 6 months. And if we are doing a surgery which is not necessary, we jeopardize that. Or if we do not do a surgery and they fracture a leg, I mean, that's quite devastating for these patients. Okay, so in those 66 patients, we have 5 fractures, spontaneous fractures, and we simulated those people. And you can see that our fracture prediction is quite okay. Yeah, so here there was a metastatic lesion more distally. We also believe it's more distally. And this is then the final result of the patients that were treated in Nijmegen. So we have 3 centers, and those are the patients in Nijmegen, our own center. The other 2 centers were not reliable because they have different CT scanners, we discovered, and the different CT scanner gives us different mechanical properties for the bones. So we use all kinds of calibration phantoms, and still it's not reliable. So currently we are going back to these 2 centers to make sure that we get adequate bone mineral density values. So we kind of recalibrate their CT scanners. Their CT scanners are calibrated almost every day. So the people, the laboratory assistants, they couldn't believe that there was so big a change until there was a big publication in America. They also compared different centers, and it was hugely different. So if you do an analysis as a mechanical engineer and you use CT scans, make sure that you calibrate it. But also, if you do a multi-center study, make sure that that calibration is done everywhere to the highest standard. Okay, so I show you only the Nijmegen patients, and you see here the failure load that we calculated. Okay, the failure load, and this is 6.5 times body weight. That's the strength of the femur. Okay, we had 6 failures, or 5 failures. So these are the failed patients, and turns out that we could pick them out quite nicely because our calculations indicate that their bones are quite weak relative to the bones of patients that didn't sustain a fracture. So if we have a limit here at 6.5, we would have said you need to operate on these 4 cases. So this would be an unlucky patient with a fractured femur. But nowadays it's 80% uncertainty. So we can help really the surgeon to make a decision. Okay? Okay, thank you for now. Okay, so we have even more time left. So are there any questions?